Hi guys, while she's getting that set up, just want to welcome you to our Rural EMS Education Series September edition. I will let Emily introduce herself, but we're very lucky to have basically an electrophysiology expert with us tonight who's going to be talking a little bit about EKGs and some other things. So without further ado, Emily, I will let you introduce yourself and take it away.
Okay, great. Well, thank you all for inviting me and for joining. My name is Emily Pasquale. I'm one of the nurse practitioners at the University of Colorado at the main campus. I practice in cardiac electrophysiology. I have been at the university for about 5 years. I've been practicing in EP since 2017. Um, so without further ado, we'll go ahead and get started. And this is mostly a basic EKG talk. We will, so can everyone see my screen okay so far?
Yes, but it's the one that
Okay.
has notes on the next slide.
Okay, hold on. There we go. Okay. Is that better?
Beautiful.
Okay. So we will sort of try to get the boring stuff out of the way. I don't want to say boring, but we will talk about sort of the electrical properties of the heart and the myocytes and different cells in the heart and how they work, and then sort of basic EKG interpretation and sort of where the different leads are placed, what that means. And then we'll sort of work towards EKG interpretation, and also go through talking about arrhythmias and then some cases at the end, which is the more probably interesting part. Um, so just to start off with the basic stuff, the heart muscle is called the myocardium. Its cells are called myocytes. Bundles of myocytes make up the cardiac muscle. They're composed of myofibrils, and contraction is induced by excitation contraction coupling. I don't know why I can't go next slide. Hold on, there we go. Okay. So in terms of electrical properties, the inside of the myocytes are all negative. So they're polarized at rest. So a resting polarized cell is negative on the inside and positive on the outside. When the cells become depolarized, the interior becomes positive and the cells contract. And depolarization sort of moves as a wavefront throughout the myocardium and stimulates the myocytes, which become positive and contract. Um, so this all begins with an action potential depolarizing these cells. Um, the calcium channels are stimulated and open. It releases intracellular calcium, stimulates these ryanodine receptors to release calcium into the cytoplasm. This finishes with calcium binding to troponin. This exposes actin for actin myosin binding. Again, this is sort of the not as fun stuff. So again, this all begins with action potential depolarizing these plasma membranes of the muscle fibers. They receive a signal from pacemaker cells somewhere inside the heart, causing them to contract. They subsequently depolarize and action potential spreads across the heart. There are different action potential phases. This is clinically important, especially when we talk about things like antiarrhythmic drugs and how they work inside the heart. But there are four action potential phases. So the first phase is that depolarization phase, where there's sort of a rapid inflow of sodium into the cell, and it causes rapid depolarization. After this, the sodium current stops, and then potassium flows out of the cell, depolarization stops, and then the cells begin to repolarize. Calcium moves into the cell, it balances the potassium moving out, and the charge balance on the inside and outside sort of creates a plateau. Calcium current stops, potassium continues to move out, and then repolarization continues. Potassium eventually approaches an equilibrium between the inside and outside of the cell. Sodium and calcium moving inward balance out the potassium, and then the resting membrane potential is achieved. So this is just sort of an image showing those different phases of the action potential and sort of what that represents on EKG in terms of what you're looking at. So to sum it up in sort of an easy way, depolarization is essentially when the myocytes become positive inside, the myocytes contract. Repolarization is that recovery phase that follows depolarization and the myocytes regain their resting negative charge. So automaticity is a property of these myocytes that allow them to generate their own electrical impulse. This is sort of a unique capability of self-excitation in the absence of any external stimuli. So this is found in a lot of different places inside the heart. So the sinus node, which is sort of our own natural pacemaker, that's the predominant pacemaker of the heart, that is generating these impulses and sort of guiding the heart rate. There are accessory atrial pacemaker cells elsewhere inside the atria, and then the AV node, and then the His-Purkinje system as well. So this is important because, again, usually the cardiac signal will generate from the sinus node. That's generally where the automaticity sort of begins, and that's what guides the heart rate. But if for some reason the sinus node were to fail, there are other myocytes elsewhere that have pacemaker potential, and they're capable of maintaining automaticity if the sinus node fails. So for example, when you see patients with a junctional rhythm and heart rate is in the 40s, that's the typical rate of the junction. And in terms of, seeing patients with heart block, you may see ventricular escape rates in the 20s to 40s. That is the automaticity in those areas sort of taking over. So it's a little more complicated than that in terms of the sinus node generating a signal. The sinus node is actually more similar to neurons. It's actually directly influenced by the autonomic nervous system. So the autonomic nervous system does all the automatic things like guide our heart rate and blood pressure. It includes sympathetic and parasympathetic nerves. Excitement of the sympathetic nerves leads to sinus tachycardia, whereas excitement of the parasympathetic nerves leads to sinus bradycardia. So thinking of sort of those vagal influences, those are more dominated in the sinus node, meaning there is more vagal input in the sinus node. Overall, there are multiple sites of innervation from the nervous system that sort of converge at these ganglion plexi that contain all these sort of nerves within the heart. And then this is just sort of an image of the pathway of conduction. I think probably most people know this, but conduction typically begins again in the sinus node. That spreads as a wave front through the atria, and then through the AV node, down to the bundle of His, the Purkinje fibers, and down to the ventricles. Okay, and so in talking about EKG waveforms, essentially it's a tracing of the electrical activity of the heart, representation of vector forces that vary with time. A vector is essentially a quantity indicated by magnitude and direction. And I think that'll make more sense as we talk about like where the leads are placed and sort of what that means. And then the different ECG waveforms that we're used to talking about are indicative of the different stages of cardiac conduction. So the P wave showing atrial depolarization, the QRS showing ventricular depolarization, and the T wave showing ventricular repolarization. So this is a picture of your standard 12-lead EKG. I think probably everyone's pretty familiar with this. So the electrical currents generated by the heart are measured by all these electrodes placed on the body surface. We call it a 12-lead EKG because it'll measure vector forces in 12 different axes. So the electrodes are placed on each arm and leg. So those are your limb leads, and then 6 leads along the anterolateral chest, which when we refer to the precordial leads, those are the precordial leads. These electrodes are connected to a device then that measures potential differences between selected electrodes, and that produces the typical EKG tracing that we're used to seeing. So Entowin's triangles, so essentially we're talking about the limb leads. So there are 4 limb leads that are placed, one on the right arm, left lower, and right lower. The right lower is neutral and doesn't appear in EKG tracing. It's a grounding lead that essentially helps minimize artifact. And these electrodes record electrical activity of the heart. So they appear as lead 1, which is measuring RA to LA, and then lead 2, RA to left lower, and then lead 3, left lower to left arm. And then composite leads are recorded to augment the limb leads. So AVF, AVR, AVL, and this forms an equilateral triangle. So again, this is just sort of repeating that similar concept. So essentially, long story short, oh, sorry, that went a little too fast. Each lead records the heart's activity from a different viewpoint. That's sort of the best way to try to remember all these things. So leads 1 and AVL are called the lateral leads because each has a positive electrode laterally on the left arm. 2, 3, and AVF are the inferior leads because each of these leads has a positive electrode positioned inferiorly on the left arm. This is important because it helps determine the direction of depolarization. So laterally, you're looking at leftward to rightward, and inferiorly, you're looking at top to bottom. In EP, we use this concept all the time to try to localize potentially where arrhythmias are coming from. And then also when we talk about later in this presentation about STEMI, this also comes into play as well. So precordial leads are all unipolar leads, 6 positive electrodes on the surface of the chest over different regions of the heart. And this is to record electrical activity in a plane perpendicular to the frontal plane. So basically, the 6 limb leads are all in the frontal plane. The 6 chest leads are all in the horizontal plane. And we're sort of going to move on a little bit now and talk about a systematic approach to EKG reading, and we'll sort of put all these things together. But if you read in this order every time, it's helpful so you don't miss anything. So RRPPQ, so rate, rhythm, P waves, meaning are there any, PR interval, and the QRS axis. So in terms of measuring the rates, I think everyone's probably used to seeing standard EKG paper. So one small box is 0.04 seconds, one large box is 0.2 seconds. So the rate, the easy way here is sort of the section here on the bottom right, where you divide or you take the RR interval, so measuring from R to R, and then 60 divided by that is sort of an easy way. Another easy way is to multiply the number of QRS complexes or R waves within 10 seconds by 6. So for example, this EKG shows 10 QRS complexes within 10 seconds. So the rate is around 60. May not be exactly 60, but it's pretty close. The next thing you'll look at is the rhythm. Is it regular or irregular? Meaning if you took calipers and you measured between QRS complexes, that interval doesn't change. And then in terms of sinus rhythm, the rules of sinus rhythm are that there should be a P wave before every QRS. There's also a QRS before every P wave. And then again, those intervals are regular between the P to P and the R to R. So I think that this one's pretty clear. The question is this sinus rhythm? And again, we'll get into some more cases later, but this is definitely not sinus rhythm. The rate is around 210. There are no clear P waves. Even though it's regularized, the rate is way too fast to be sinus tachycardia. So it's not sinus rhythm. It's definitely an arrhythmia. It's atrial flutter. But again, we'll get into some more in-depth cases further on. In terms of this EKG, this definitely looks like sinus rhythm. If you were to take calipers and measure, the R to R intervals are all regular. There's a P wave before every QRS. So this is sort of a textbook sinus rhythm EKG. And then last one here. So this is a little bit of a tougher one. There's sort of a lot going on, but the R to R intervals are not regular. If you look, there aren't really any clear P waves. So it's not sinus rhythm. For people who are really advanced at EKG reading, it's AFib, and you can see that there's intermittent pacing as well. Okay, so in talking about the limb leads, again, this is talking about superior and inferior. So again, 2, 3, and AVF are looking at top to bottom, and then the lateral leads are looking at right to left. The precordial leads are also looking at right to left, but more so anterior to posterior forces. So when we look at EKGs, again, the vector sort of shows us the direction of depolarization. And when we're looking at axis, we're looking at the depolarization of the ventricular myocardium specifically. The QRS axis overall, so when you read EKGs, if you see things like left axis deviation, right axis deviation, this is the sum of the QRS vectors in 1 and AVF, because again, remember the limb leads look at right to left and superior to inferior forces. Generally, the QRS vector should indicate that the ventricular depolarization is traveling down and to the left. And that's between 0 to 90 degrees. This vector may change depending on other factors. Even things like the patient's body habitus can change the axis. So a normal axis, again, is downward to the left. Again, imagine, again, that the signal's traveling down the bundle branches and to the left. Left axis deviation means it's traveling upward to the left. And then right axis deviation is downward or upward to the right. So right axis deviation you'll see is negative and 1. Like, so again, this is the lateral leads. We're looking at right to left. So when lead 1 is negative, the signal is traveling rightward. So the opposite would be true if lead 1 were positive. It's traveling leftward. When lead 2 is positive, again, we're looking at forces going top to bottom. So when the inferior leads are positive, that means it's inferiorly directed, so the depolarization is traveling down. AVF is positive, so again, that's one of our inferior leads, so it's traveling down. So this is what you'll see with right axis deviation on an EKG. Left axis deviation is essentially the opposite. So again, positive in 1 means it's traveling leftward, and then negative in the inferior leads, meaning it's traveling upward. And before I move on from this, these are not necessarily things that are pathogenic. You may see them on EKG, and it may or may not be necessarily clinically important. So next, talking about wave progression. So R wave progression, the R waves should increase in size from V1 to V6. The ventricular mass increases when you're progressing further left. The left ventricle is the biggest muscle in the heart, so remember it that way. S waves should decrease in size from V1 to V6, and T waves should progress to upright the further you get across the precordium, so from V1 to V6. So you will see things also on EKGs, such as left ventricular hypertrophy and right ventricular hypertrophy. So left ventricular hypertrophy, the QRS voltage in the left and lateral leads. You'll see a really, really tall R wave in V6 and an increased deep S voltage in V1. And a negative T wave in V6. Right ventricular hypertrophy is the QRS voltage in the right and anterior leads. So you'll see increased R wave voltage in V1 and then deep S voltage in V6 and sometimes a QR pattern in V1. And then atrial hypertrophy is something that's a little bit harder to see on EKG. But you can sometimes catch this as well. Right atrial enlargement, you'll see tall P waves in lead 2. Left atrial enlargement, you'll see prolongation of the P wave duration in lead 2. And then sometimes they'll look biphasic where you'll see this sort of little hump here. Okay, and then again, I think a lot of people probably know these things as well, but these are things that we do measure on EKG. So the PR interval, and these are sort of the normal ranges. Obviously that can vary slightly, but the PR interval should be less than 0.2 seconds. So one of those large boxes. The QRS should be less than 0.12 seconds. So 3 little boxes. So we're talking about a wide versus narrow QRS, and we will talk about bundle branch block in this presentation as well. And then the QT interval, less than 460 milliseconds. And that's sort of a blanket number. It can vary a little bit based off of gender. One thing to remember about the QT interval is it varies with heart rate. So if your patient is tachycardic or bradycardic, that's going to affect what the QT interval actually is. So we call that the QTC, that's the corrected interval. So the QT corrected for the heart rate. And then the ST segment should be horizontal and isoelectric. Elevation or depression of more than 1 millimeter and more than 1 lead is abnormal. So in terms of QRS duration, like we talked about, the QRS should be 120 milliseconds or less. However, technically a normal QRS is 80 to 100. When it's over 100 but below that 120, we sort of just call it an intraventricular conduction delay, just meaning there's a slight delay in the signal traveling from the right to the left ventricle. There is intraventricular conduction. Bundle branch block is when the QRS is over 120 with the patterns below. So again, the heart has two bundles, a right bundle and a left bundle, which supply each ventricle. And so essentially, if a patient has a right bundle branch block, that means that the signal can't travel all the way down the right bundle. And the converse is true for the left bundle. And again, because of intraventricular conduction, wherever the block is, that ventricle will still get depolarized eventually. There will just be a delay. And so that's why the QRS is so wide. So this is what right and left bundle branch look like. V1 is generally the easiest lead to sort of characterize these. In V1 for right bundle branch block, you'll see these sort of two peaks, they call it like bunny ears. And then with left bundle branch block, you'll see this deep S wave. And then also a really wide R wave in V6. As you see these more and more, it becomes easier to identify them. And again, these are things that while they're abnormal, they may or may not be pathogenic for the patient. People can have these bundle branch blocks and be completely asymptomatic, otherwise normal heart, those sort of things. So ST segments, like we talked about, they should be flat and horizontal to the baseline. Elevation or depression of more than 1 millimeter in more than one lead is abnormal. That indicates that there's some injury to the myocardium. We see these things obviously in acute MI. You guys are probably used to seeing these things in the field. Diffuse ST segment elevation is more commonly seen in pericarditis. That's usually not associated with acute MI to have diffuse ST segment elevation across all the leads. J point elevation is something that can be normal, where you can see some ST elevation across the precordial leads. And this is relatively common in younger patients. So just be aware of that early repolarization is a normal pattern. So this is sort of, again, what we're talking about in terms of where the leads are placed and when we see patients come in with acute MI and where the ST segment elevation is and what area that correlates to in terms of where their culprit lesion may be, meaning when we take them to the cath lab, what do we see as occluded? And so the inferior leads are essentially, again, looking at the inferior part of the heart. So that's usually the right coronary artery, sometimes the circumflex, but mostly the right coronary artery. And then the precordial leads, so again, going across the chest, is mostly looking at the LAD, although as you get further across the precordium, you could also be looking at the circumflex or the RCA. So these are different things to be aware of. You know, again, when you get a call for a patient with chest pain and you see a STEMI, sometimes it's relatively easy to guess when the patient goes to the cath lab what they're going to be fixing. So QT intervals. So again, as I mentioned to you, that 460 is sort of a blanket number. These are sort of the more normal criterion for normal QT and QTC based off of age and gender. So again, as I mentioned to you, you do need to correct for the heart rate. The QT interval is clinically important because as the QT interval prolongs, it increases the amount of time the heart is excitable. And so that increases the risk of ventricular arrhythmias and sudden cardiac death. So there are delayed after depolarization. So signals that can happen, there's spontaneous depolarization. Sometimes that occurs in the heart. And if that happens during this sort of vulnerable period, that can lead to these malignant arrhythmias. And this can be something that's drug-induced, where patients are taking multiple QT prolonging drugs, or genetic. It can also be related to substance abuse. So things like alcohol and drugs, things like that can alter electrolytes, and that can cause the QT to prolong as well. Okay, so now talking about arrhythmias. So bradyarrhythmias obviously are slower heart rates. So sinus block means that essentially the sinus node stops. This causes sinus pauses. Again, remember that the junction can take over. So sometimes you'll see, a sinus beat and then a pause. And instead of another sinus beat like this strip, you may actually see a junctional beat. And that'll look different because you won't see a P wave. This can be evidence of sick sinus syndrome, so meaning someone's sinus node isn't working that well, which is more common in elderly patients with or without heart disease. If it's a younger patient, um, if they have a history of heart disease, like they don't have a normal heart, they've had prior surgery, they may really have sick sinus syndrome. But again, we need to remember that the parasympathetic nervous system innervates the sinus node. So you may see young, healthy people exhibit this at rest because the vagal tone is high. And there are other things that can increase the vagal tone. So, for example, if you have a patient that you get called to come see and they're vomiting and they have diarrhea and stuff like that, that may also trigger the vagal nerve, and we may see things like this. And it doesn't mean that they need a pacemaker, maybe sort of a normal finding. And as the vagal tone goes down, they stop having this. And same thing goes for nighttime. We do see this a lot, especially when we give patients like wearable monitors and things like that. Patients that have sleep apnea, or just in general, people are sleeping and they have things like this. And it's mostly just because the vagal nerve is being stimulated while they sleep. So I'm a big basketball fan, so I included this in there. But this is just kind of a reminder that, again, to treat the patient, not the number. There are many people who are really cardiovascularly fit, and their average heart rate may be in the 30s to 40s. And if they're not symptomatic with it, there's really, really nothing to do about it. So obviously bradyarrhythmias aren't limited just to slow heart rates and pauses and things like that. There are different types of heart block. So first degree AV block is essentially the PR interval is more than 0.2 seconds. So if you measure from the P wave to the R, it's more than one large square. This just means that there's a delay in the signal traveling from the atrium to the ventricle. What that means is there's disease at the level of the AV node, so that conduction is just slow. This is usually not symptomatic and doesn't require any treatment. Rarely we see that this could be symptomatic, but the PR interval has to be really long. The only time that we've ever really put pacemakers in these patients is if the PR intervals, like we're talking close to 400, 500 milliseconds. Generally, what you'll see also is that as patients become more active, that conduction through the AV node sort of starts to slick up and that PR interval tightens. And that's a normal physiologic response. So if someone has a first degree AV block at baseline, there's usually nothing to do about that. And that's not indicative that they're going to develop some form of higher grade AV block or anything like that. Second degree AV block can be benign or not benign. So I'm sure everyone has heard of Winky-Bach. So that's type 1 second degree AV block. So essentially, and I think I have strips on the next slide, the PR interval gradually prolongs with each cycle, and the final P wave is totally blocked. So then you'll see your dropped QRS. This is usually benign, doesn't require treatment. This is most often vaguely mediated. So again, we'll see this a lot at nighttime or in settings of high vagal tone, that sort of stuff. Type 2 is pathogenic, so it's lower. It's not at the level of the AV node. So now we're talking about the His-Purkinje system. There are consistent PR intervals with the conducted beats, but there are occasional non-conducted beats. Most of the time, this results in the need for permanent pacing, especially if it's happening while the patient is awake and they're symptomatic. Third degree AV block is definitely pathogenic. This patient needs a pacemaker. Essentially, there's complete block of conduction from the atrium to the ventricle. So they're not communicating with each other at all. And so here are some strips. So again, in this first one, there are no drop beats, it's a short strip. But if you measure, this PR interval is pretty long. And again, that's a benign thing. And then in the second strip, so with Winky-Bach, if you took calipers and you measured each of these PR intervals, you would see it's getting longer, and then drops. Sometimes it can be hard to see the PR interval prolonging significantly. This is pretty marked where you can see it easily on here. One other way that I've found is sort of easy to identify is the next sinus beat that comes in after the dropped P wave, is that PR interval shorter than the PR before that? If the answer is yes, it's probably Winky Bach. It's also pretty common with Winky Bach to see grouped beating, where again, there's a few beats together and then that drop beat. And then this strip here with second degree AV block, if you measure these PR intervals, they're all consistent except for these drop beats. And then sometimes you can also see 2-to-1 AV block. This can be a little more challenging to suss out where the level of block is. Sometimes what we will do with these kind of patients is get them up, walk them around, see if they have better conduction as the heart rate goes up. If that's the case, that means usually it's at the level of the AV node. They probably don't need a pacemaker. But this one could be a little bit tougher to sort out. Either way, this patient, if you see 2-to-1 AV block, they definitely need some sort of workup and evaluation. And then this last one here is a complete heart block. Again, you can see none of the P waves are conducted, meaning there's no QRS following these P waves. The atrial and ventricular activity are completely independent of each other, essentially. And so you can see here the ventricular rhythm. This is probably a junctional escape. So most patients have some ventricular escape, even in complete heart block. And you'll see rates really anywhere from 20s to sometimes as robust as like the 60s. But again, if you see that, the patient definitely needs to come to the hospital for sure. So tachyarrhythmias are rapid rhythms. Generally, this is from irritable automaticity foci in the heart, meaning there are cells somewhere in the heart that are irritable and sort of misfiring. SVT is really an umbrella term for any fast heart rhythm that comes from the atria. The origin of SVT can often be recognized by rate alone. And then ventricular tachycardia or ventricular fibrillation originates obviously in the ventricles. So when we talk about SVT, there again are different types of SVT. So AFib and atrial flutter actually do fall under the umbrella of SVT, because again, it's just sort of an umbrella term for any fast heartbeat from the top part of the heart. They are a little bit different than other types of SVT, just in terms of talking about the risk of stroke, which we'll get to that as well. But the way that we sort of classify different tachycardias in EP is long RP and short RP. So if you look at these strips here, what you can see is that SVT here, where the P wave is likely retrograde, meaning the P wave comes after the QRS, and then here where the P wave precedes the QRS. And so for us, sometimes this helps us be able to sort of localize potentially where the SVT is coming from. The most common type of SVT that you will see, especially in younger patients, is AVNRT, which is an abnormal circuit going around the AV node. And with that, typically you'll see retrograde P waves. So atrial tachycardia is less common than AVNRT. So essentially atrial tachycardia is due to abnormal automaticity. It's not a reentry circuit. There's sites somewhere else in the atria, could be right atrium, could be left atrium, that are generating the signal, not the sinus node. The rate's usually anywhere from 150 to 250. This accounts for like 5% of SVTs when we go in and do an EP study. If we have a patient who has SVT and we're not sure where it's coming from, we go put catheters in, try to induce it. This is not the most common thing that we see. If you are going to see this, the most common sites are the right atrial appendage near the coronary sinus, or the left atrial appendage or the pulmonary veins. And that's sort of akin to AFib. This is, again, one of those things where we talk about EKG vectors, sometimes we can try to localize where it's coming from based on what the P wave looks like. Sometimes there are certain atrial tachycardias that look like sinus tachycardia, and that can be challenging. Generally, if you have a patient with atrial tachycardia and you try to give adenosine, which definitely I would assume is something that some of you probably try to give patients in the field for SVT, it usually doesn't work. What you will see is that there are P waves that are non-conducted when you give the adenosine. It will not actually terminate the arrhythmia. You can give AV nodal blocking agents for this. So, beta blockers, calcium channel blockers, antiarrhythmics are effective. Cardioversion can also be utilized if the patient's not stable. So AVNRT, this is different. This isn't really automaticity, meaning it's not abnormal cells that are firing somewhere. This is a re-entry circuit around the AV node. So most of us only have one pathway down the AV node. Some people have two. And so the way when I explain it to patients is there's a slow pathway and a fast pathway, and they have different refractory periods. So the slow pathway has a really short refractory period, meaning that it doesn't take long for the slow pathway to recover and be able to accept another signal. The fast pathway is the opposite, where it has a really long refractory period and it takes a long time for it to recover and accept another signal. So it's sort of like traffic lights. And so typically what happens is the signal will conduct down the fast pathway. The patient will have a premature beat or something like that. Because the fast pathway is still in refractory, again, I mentioned has a long refractory period, it's not ready to accept another signal. That's premature beat will travel down this extra pathway here. By the time it gets to the bottom of the AV node, now the fast pathway is not in refractory. That signal travels upwards and downwards, and it creates this re-entry circuit around the AV node. This is the most common type of SVT that we see in patients, especially young patients, but this makes up typical AVNRT, which I just described to you, makes up like 88% of the SVTs that we see. This is that common type of SVT where usually it's responsive to vagal maneuvers. You have your patient bear down, or if you give adenosine, usually it will break AVNRT. If you see this, for these types of patients, generally we recommend ablation. The success rate is like 90-95%. A lot of times it's not super responsive to like long-term drug therapy, meaning if you give adenosine in the field and it breaks it, great. But giving patients drugs like metoprolol and stuff like that long-term usually isn't super effective. So atrial flutter is organized atrial activity. Instead of the atrium squeezing and contracting, normally it's just fluttering. So the atrial rate is very rapid. The atrial rate's anywhere from 250 to 350 beats per minute. As I mentioned to you, the AV node has a refractory period. So not every atrial beat is going to conduct down to the ventricle. The ventricles can't beat 350 beats per minute. If they are, that's not a good thing. So generally you'll see a pattern of 2 to 1. So meaning that if the atrial rate's 250 or 300, you'll see a ventricular rate of around 150. And so atrial flutter is that classic sort of sawtooth pattern that I have here, mostly in the inferior leads. That's where it's easiest to see that pattern. And that is most consistent with typical atrial flutter. And again, we say typical, we mean like the most common type of atrial flutter. And that's usually a circuit that is around the cavo-tricuspid isthmus, so near the tricuspid valve. So usually you'll see positive flutter waves in V1, and then this negative deflection in the inferior leads, that sawtooth pattern in the inferior leads. This is also oftentimes not very responsive to drugs. You can give medication to try to slow it down. You can do cardioversion. The only thing I caution talking about atrial flutter and AFib in general is unless your patient's unstable, may not be ideal to just do a cardioversion without knowing how long they've been in the arrhythmia or if they're anticoagulated. There is a risk of atrial thrombus forming in AFib and flutter. Again, because the atria aren't squeezing and contracting normally, some blood just pools there and can form a blood clot. The main issue if you chemically or electrically cardiovert these people is that you dislodge that clot and potentially cause a stroke. So in patients who have AFib or flutter, generally we recommend anticoagulation. So AFib is different than flutter in the sense that it's disorganized. The atria are still beating really rapid, and the atrial rate is much faster actually than flutter. It's around 350 to 450 beats per minute or even higher than that. And the ventricular rate is much more irregular. So you'll see this wavy baseline, sort of this coarse isoelectric baseline without any visible P waves. There are lots of management strategies for AFib. Patients who have AFib generally need anticoagulation unless they have a very low stroke risk. Again, I would caution cardioverting people unless they're truly unstable, meaning blood pressure is low and those sort of things. Um, the other thing I would caution is over beta blocking, or I guess AV nodal blocking agents in general. I think it's fine to attempt, but sometimes these patients, we don't know what their ejection fraction looks like when patients are in long-standing AFib or flutter, and the heart's been beating rapidly for a long period of time. Again, the ventricles are a muscle, especially the left ventricle, and so over time, if it's beating really rapidly, the ejection fraction can decline. And so we have seen patients where people are just giving them diltiazem and metoprolol and all those things, and eventually they just sort of crash because those drugs have a negative inotropic effect. So they reduce how well the heart is contracting. And so I would caution that as well. A lot of times patients can tolerate AFib and flutter relatively well. Sometimes it can obviously cause hemodynamic instability when the ventricular rates are really rapid and they are hypotensive. And in that case, it may make sense to cardiovert them on sort of risk versus benefit, even if they're not anticoagulated. They should definitely be anticoagulated after cardioversion, though, because there is some stunning of the myocardium after we do that. Okay, so VT. So we're going to talk about ventricular arrhythmias now. This is generally very sudden. It's usually automaticity related, but some patients may have a reentry circuit in the ventricle, especially patients who have had history of prior MI. Most of the time, ventricular tachycardia comes from scar tissue inside the heart. So we see this very common in patients who, again, have had prior MIs. This is going to be wide complex. The rate's going to be anywhere from 150 to 250. I will say 150 is a little bit on the slower side for VT, but occasionally, on our end, we see VT as slow as 100 beats per minute. So you never know. Monomorphic VT essentially resembles a run of PVCs. That's essentially what it is. Polymorphic VT, again, you'll see these changes in morphology. Occasionally, you can still see P waves. The sinus node may still be working, but there's no association between the atrium and the ventricle, meaning there's no pattern. Obviously, for this, you're going to follow ACLS or BLS if they're pulseless. Torsades is a little bit different. And this is sort of a specific ventricular tachycardia pattern, but this is usually due to electrolyte abnormalities or medications that prolong the QT interval, or again, in patients who have some sort of genetic disorder that prolongs the QT interval. Torsades is usually treated with magnesium, which is a little bit different than other forms of VT. VF is a type of cardiac arrest. There's no organized cardiac activity, essentially. There's no effective cardiac output. The ventricles are essentially just twitching. For this one, you're going to have to do BLS, ACLS, those things. Patients are not conscious when they have VF. In EP, our practice when we see patients who have had VF is to look at why did this patient have VF. Most of these patients are going to get an ICD if this is their first time having this type of arrhythmia. Some of these patients you may see in the field, they may already have an ICD, and if they have one, it should be treating this. This patient needs antiarrhythmic drugs for sure, and we'll definitely be getting a workup in the hospital. All right, so now we're going to review some EKGs. And then again, we'll get to some cases in the end. So again, the rules of sinus rhythm: P wave before every QRS, QRS before every P, regular P to P and R to R intervals. Sinus P waves should be upright in the inferior leads and downward in AVR. So if you look at this EKG, there are P waves before every QRS. It looks regular if you measure between QRS complexes. This EKG definitely looks like sinus rhythm. This one here, same thing. There are P waves before every QRS. If you measure, though, it is slightly irregular. And to me, this rhythm looks like sinus bradycardia, probably with some premature atrial contractions thrown in there. Um, this one here, same thing, P wave before every QRS. Um, looks regular, looks like sinus tachycardia. This one, this one here is definitely not sinus rhythm. There is clear atrial activity. You can see P waves, but not all those P waves are conducted. There's not a QRS after each P wave. So this is actually a 2-to-1 AV block. Um, and one of the further cases also has has a good EKG with AV block. This one here is definitely not sinus rhythm. If you look at it, there are no P waves before the QRS. To me, this looks like some sort of atrial flutter. Um, and then this EKG here, again, there's a P wave before every QRS. However, it's not regular, and you can see that there's some wide complex beats sort of thrown in there. This EKG is sinus with PVCs. And this one is actually pretty easy. This is like a nice textbook EKG for atrial flutter. You can see that sawtooth pattern really well in the inferior leads. This is like a perfect atrial flutter EKG. Okay, so now we're going to go through some cases. So I'm hoping that people maybe want to participate, but if not, and when we talk about these cases, these are actually patients of mine that I've seen in the hospital and or in clinic. And so I know one thing you guys probably don't always get to hear is what happens to the patients after you drop them off at the hospital. So we'll talk about how they presented, what their EKG showed, and then also what actually happened to them. So this first patient, you get a call from their primary care doctor's office that they're an SVT. The patient came in just for a routine follow-up visit when they noted his tachycardia, when they were taking his vital signs. So they did a 12-lead EKG, which is on the next slide. This guy's 51, but he has a pretty extensive medical history. He has a history of mitral valve replacements. He's got a mechanical mitral valve and also a tricuspid valve that is bioprosthetic. And they did an ablation during his procedure. So he has a history of AFib and flutter. He's also had a couple cardioversions. After his cardiac surgery, he had complete heart block. So they put a pacemaker in 2014. He also has high blood pressure and sleep apnea. His vital signs in the clinic, his heart rate's 210. His blood pressure is 98/64. His oxygen is fine. He at home he takes metoprolol and warfarin, obviously for his mechanical valve, but he said he hasn't really been taking them regularly. And so this is the EKG that they hand you. What do we think, think that this is?
And feel free to type it in the chat, guys. I'm monitoring the chat.
Yes, that's great. I was gonna say I can't really see the chat, but
What rhythm do you guys think this is? Is it sinus? Is it ventricular? I have an SVT.
yeah, I mean, SVT is definitely a correct answer. I don't think, oh, sorry, that we have to get too much more in depth than that. I think SVT is a great answer. It's regularized, it's very rapid. Again, the rate's about 210. It's narrow complex, so it's not a ventricular arrhythmia. So to further differentiate from if you're sort of an advanced EKG rater, you may be able to see there are some flutter waves here in V1 and in the inferior leads. So this patient is actually an atrial flutter with RVR. I'm curious, I guess, on your guys' end, how you would manage this patient. It sounds like he's hemodynamically stable. He's not super symptomatic. Again, the way we manage things in the hospital is probably a little bit different. And I will tell you what we did for him.
What are you guys going to do with this patient? Are you going to cardiovert him? Are you going to let it ride? You're going to give him fluids? What do you think? I have a supportive.
Yeah,
Yeah. Oh, you can see
yeah.
the.
Yeah, I can see it now. Yeah, I think that's a great answer. He is feeling okay. His blood pressure is okay. He obviously needs to probably be taken to the hospital, so we can try to get him out of this. Because how long he'll stay hemodynamically stable, I don't know, with a heart rate of 210. But yeah, supportive care would be reasonable. So what actually happened to him? This is actually one of my clinic patients. He came to clinic like this. So, and he was feeling fine. So we sent him down to the ED. His INR was subtherapeutic in the ER. As I mentioned earlier in the slide, he's not been compliant with his warfarin. So we didn't do a cardio version, just out of concern that he could already have a thrombus there. And so he was given IV metoprolol for rate control. Ultimately, he was able to be rate controlled. His echo showed normal heart function. We've talked about doing another ablation for him. He's had multiple already. This EKG is consistent with atypical flutter. So I think we talked about earlier in the presentation that typical type of atrial flutter that comes from near the tricuspid valve. Essentially, atypical flutter is anything that doesn't look like that typical EKG. You'll see atypical flutter more commonly in patients who don't have normal hearts, meaning they have some structural abnormality, or in patients who have had prior cardiac surgery, which he has. That's usually because with cardiac surgery, they will leave scarring in the atrium when they make their atriotomy. Unfortunately, this patient we've had him on sotalol before, Tecousin before, which are antiarrhythmic drugs, but he has a pretty strong history of depression and bipolar, and he's actually tried a couple times to commit suicide with his antiarrhythmics. So he's a very tough case, but that's him. So in terms of the next case, you receive a call from a patient that's gotten multiple ICD shocks. So they're at home. This patient's 60 years old. He has a history of substance abuse with cocaine and meth. He has a history of coronary disease. He's had a couple stents put in, nothing recent. He has known heart failure. His EF is 21% by echo. He's had a VT arrest before. So again, he has an ICD. That's why he called. He said he's gotten shocked a couple times. He's had a prior ablation. He also has high blood pressure and sleep apnea. So when you get there, he is doing okay. His heart rate's 80. His blood pressure is 99/72. His oxygen's 92%. He said he's been taking all of his medications. He's on amiodarone and mexiletine and carvedilol. He said he hasn't used drugs recently. He starts to feel crummy again, and so you get another EKG, and this is what his EKG shows. What do you think of this rhythm? VTAC, yes, that's right. That's definitely right. It's wide complex. There may be some P waves hidden in there in the precordial leads, but there's no AV association. It's definitely VT. How are you managing this patient right now? He's awake, he's talking to you, he feels okay, but he can tell that his heart rate is elevated. Pad IV monitor. Yeah, I think that's definitely a reasonable place to start for sure.
Would you guys do amiodarone on this person? That's pretty much the only antiarrhythmic most agencies carry.
Amiodarone's very reasonable. The patient is on oral amiodarone, which you may have some success giving him IV amiodarone. I don't think that's wrong at all. That would be very reasonable to give him amiodarone since he's again awake, talking to you. He's got a pulse. Again, he also has a defibrillator. The defibrillator is probably going to go off again. So this patient is also one of my patients I took care of in the hospital recently. So his VT terminated spontaneously in the ER. He was given a lidocaine bolus and started on a lidocaine drip. We held his oral mexiletine. So mexiletine, for those of you who don't know, is essentially an oral lidocaine analog. So it's basically oral lidocaine. So they don't need both. He was not really felt to be a good candidate for ablation. Ordinarily, we'd consider potentially going in and doing ablation for someone like him. But because of his history of substance abuse, he also has really poor follow-up. His heart failure is really bad. We didn't feel like there were any bailout options if ablation didn't go well. So for him, we decided to do something called SBRT. So that's essentially where we do radiation therapy for VT. So it's another form of ablation, just not that typical form where we use catheters. So there are multiple studies done on radiation therapy for VT. So akin to like radiation therapy you'd use for cancer, it's a single dose of radiation. He actually had another cardiac arrest in the hospital while he was undergoing cardiac MRI. We have to get imaging to plan where we're going to deliver radiation. And we turn off their defibrillator for the MRI because the MRI causes electromagnetic interference and that can cause the ICD to go off. And so he actually was resuscitated down in MRI and then was brought to the ICU. He had actually been on the floor at that point doing relatively well and started having VT again in the ICU. His device did deliver an internal shock, which was successful. He was also started on procainamide. Ultimately, he had the radiation. He hasn't had any more arrhythmias since then, which is fortunate. So we don't have a ton of other options. So this is the last case, I think. So you get another call from a primary care office about a patient with bradycardia. She came to her PCP because she's been feeling really tired. And also she's been having dyspnea and exertion. They don't have the ability to get an EKG. They don't have an EKG machine at their office. But they note that her vital signs show a heart rate of 36. Her blood pressure is 166 over 72. Her oxygen's 98%. She's 69. She has a history of extracardiac sarcoidosis, hypertension, and osteoporosis. She's relatively healthy. The only medicines she takes are amlodipine and olmesartan. So you get an EKG after you get there, and this is what her EKG shows. What do you think of her rhythm, and how would you manage her? Oh, yeah, that's right. Yeah, it is high grade AV block for sure. If you look at the P waves, none of them conduct any of the QRSs. So it is definitely high grade AV block. What would you do for her? Again, she's not feeling great, but her blood pressure is okay. She's hemodynamically stable. Yeah, I agree. Yeah, I don't think you need to do anything for her. To be honest, there's probably not all too much you can do in this situation. You could try medication. Better have the pads on. Yes, I agree. Yes. If you need to transcutaneously pace, you could. I would say if she becomes hemodynamically stable or you lose a ventricular escape, she would need to be transcutaneously paced, obviously. Atropine usually isn't super helpful for high grade AV block. Mostly works at the level of the AV node. So you won't really see that it's that effective. Sometimes it can make it worse. So for this patient, she is also one of my patients. We did get called from her PCP. They actually were the ones who got that EKG. Given she was hemodynamically stable, we didn't give her anything. We didn't echo in a cardiac MRI to decide what type of device we're going to give her. So there was one sort of little clue in the history that she has a history of sarcoidosis, which is related to these granulomas forming in different parts of the body, and it can affect the heart where there are granuloma deposits inside the heart. And so if someone has evidence of that, potentially you would give them a defibrillator instead of a pacemaker. Her MRI was normal. And even when people don't have that history, if they're relatively young, we will consider doing advanced imaging to see if there's something else going on. I believe the current guidelines are for patients less than 60. Idiopathic high-grade block, meaning high-grade block just for no reason other than their conduction system doesn't work well, is very rare. And so we will try to look for, is there some underlying cause? You can get an MRI after the fact, but it can be very hard to get a good quality MRI once you have a pacemaker put in. So she did have a pacemaker put in, and we did do genetic testing as an outpatient that was also negative. So essentially, we felt like her heart block was idiopathic. We didn't have a good explanation for why exactly that happened to her, but she's done well since she had her pacemaker put in. So I guess I will stop for questions. That's all I've got. I think this is the QR code they gave me for you to be able to scan for, I think, education credit.
Yep, you got it. These folks know, but that's how you get your CE in case anybody.
Okay. Let me know if I need to stay.
I have a question.
Yeah, sure.
Pre-hospital, we've kind of taken lidocaine out of a lot or most
Yeah,
ambulances.
yeah.
But I know that electrophysiologists tend to really like lidocaine over.
Yeah, we do.
Can you tell us a little bit about why that is?
Yeah, I always tell people like the longer I practice in EP, the harder ACLS gets because the things we do don't fully align with ACLS. For us, one of the benefits of lidocaine compared to amiodarone is partially the half-life, actually. Amiodarone has a long half-life, meaning it takes a long time to clear out. And so a lot of these patients, when they come in, we will consider doing an ablation while they're there in the hospital. And so it is sometimes easier for us to induce VT. So for those of you who don't know what we do during an EP study and ablation, we put catheters up inside the heart and we try to induce the patient's VT. So essentially we can map it. So you're out where it's coming from and ablate it and try to get rid of it essentially. And so amiodarone can make it more difficult to induce patients. Lidocaine is a much shorter half-life. So if there's any possibility the patient's going to have an ablation done, we'll use lidocaine. Obviously, you guys don't have to make that decision. I think the most important thing is getting patients stabilized. So if amiodarone is the drug of choice, I think that that's perfectly fine. Some patients are already on amiodarone as well if they have a known history of VT. And so if they already take PO amiodarone at home, they may be relatively well loaded, and potential that IV may not be that effective, especially if they're in VT storm where it's just persisting. But those are our thoughts on lidocaine.
Thank you. Any other questions, guys?
Yeah, thank you guys for having me. Also, thank you guys for everything that you guys do. You guys probably, we have a lot of patients come from a lot of places. So some of you guys probably have taken care of some of our patients and kept them alive. So thank you. If you ever have any questions, you can always send me an email. But hopefully this was helpful.
Yeah, thank you so much. This was great.
Yeah,
Bye.
no problem.